Hello, I'm Todd Didier, Communications Director for the Primary Care Collaborative. Every month, the PCC recognizes outstanding leaders from across the nation who are working to strengthen primary care. Today, we're thrilled to recognize Dr. Wayne Altman, Professor and Chair of Family Medicine at Tufts University School of Medicine. Dr. Altman is also the founder of Massachusetts Primary Care Alliance for Patients, or MAPCAP, which advocates for anti-racist health policy that features an emphasis on social determinants of health, a prospective global payment for primary care, and the doubling of investment in primary care. So you can see why he's our champion this month. Wayne, thank you so much for joining us. We're thrilled to have you.
Thank you, Todd.
So, Wayne, you've been a long time champion of primary care. Can you tell us a little bit how you became a primary care champion, what motivated you to go into primary care yourself, and why you're so passionate about strengthening and delivering high quality whole person primary care?
Todd, I very much identify as an advocate, but I also identify as a medical educator. And I've been teaching medical students for close to 30 years now. And, when I'm teaching them, there's a part of me that's trying to inspire them to choose a career in family medicine. And for a while, we were matching, close to 20 or 25 students out of 200, maybe about 12% of graduating medical students at Tufts into family medicine. And the American Academy of Family Physicians described us as a positive deviant at Tufts, which I think was a compliment. I'm not entirely sure. And I was touched by the compliment, with our team at Tufts. At the same time, getting 20 people to go into family medicine out of 200, it's not going to cut it. It's not nearly enough. It's not even remotely in the ballpark. And it's getting worse and not better. And ultimately, it's our healthcare system that's failing. And that is what needs to be addressed. That is what inspires me to try and affect positive change in primary care, in our healthcare system. We just had match day about a month ago. And in Massachusetts, out of the approximately 700 graduating medical students, less than 4% chose family medicine and matched in family medicine. That was devastating. So I think that what we need to do to get medical students to start choosing family medicine in much higher numbers is to both fix the job and fix the pay. When I'm talking about fixing the job, I have so many medical students, and my colleagues report this as well. They'll look at us in the work that we're doing in our offices and they'll say, "Boy, you're doing God's work." And then they pause and look at you and say, "Good luck with that."
You have been working very passionately on this in Massachusetts with your group MAPCAP and with other passionate members of the primary care community. Uh, what advice or what recommendations would you give to other primary care champions working on state level advocacy? And what are you still hoping to achieve in Massachusetts? Because obviously we still have a lot of ways to go, both at the federal and at the state level, even in leading states like Massachusetts.
We have very bold goals in Massachusetts. We are hoping to pass landmark, historic primary care legislation in 2026, and we feel confident that we will achieve that goal. Now, we've been at it for 8 years, and people told us it would take 10 years. And I thought, ain't nobody got 10 years to wait for this. For those who know me, I'm not the most patient person, but I guess good news that we'll maybe achieve this 2 years early. In terms of advice, what occurs to me is that I think the superpower you need to achieve major legislation or this kind of success is the same superpower that primary care clinicians have, which is building relationships. The primary care superpower of generating health and equity all at a lower cost, I call that the primary care triple superpower, that is generated through relationships. Relationships is the secret sauce of primary care that generates those superpowers. And it's the same thing that you need for advocacy, is building relationships with lots and lots of different stakeholders and really listening to their perspectives and their concerns and their needs. There's like 1,000 steps, 10,000 steps to getting major legislation like this passed. And the way you can move quickly and efficiently through those steps is when you know people and when you have connections with people and when you can text people and say, hey, can we chat for 3 minutes? Do you know this person? Can you connect me with this person? So having relationships, the old expression is it's all who you know. And it's not the most equitable, but it is realistic. And you need to have relationships with folks and know folks to be able to knock down doors and make stuff happen.
We talked a little bit about this at the top, but uh, a major driver of the challenges that primary care faces has been a lack of investment and also just a general undervaluation of primary care in general. Could you talk just a little bit more about what has the impact of that been? What if I'm a patient and I'm in an area that has really started to see the effects of this underinvestment in primary care? What am I experiencing, and why is it so critical that policymakers and others address this underinvestment?
We've got this extraordinarily powerful health policy lever in primary care. And for some reason, we seem unwilling to pull that lever and generate the outcomes that we're looking for. Quite honestly, in the United States, one of the richest countries in the history of the planet, we have embarrassingly poor outcomes in all different domains, including preventable deaths. Uh, we rank very poorly amongst our peer nations in that domain and so many other domains. Furthermore, we have people who are sick, in pain, in crisis, who can't access care or don't know where to access care and end up in emergency departments or not getting care at all. So we have an access crisis. We have a health crisis. We also have an affordability crisis where healthcare is outrageously expensive because we're not utilizing enough primary care. And lastly, we have an equity crisis still in 2026. I can tell you in Boston, if you are in a neighborhood called Back Bay and ride or walk 2 miles down the street to a different neighborhood called Roxbury, the difference in life expectancy is 23 years, 2 miles down the road. In the Back Bay, the average life expectancy is 92, and in Roxbury, 69. Can you imagine that? A 23-year difference in life expectancy just 2 miles down the road. Primary care can fix that. Primary care can fix health disparities. It can fix access. It can generate better health, and it fixes affordability.
Drilling into things just a little bit, are there specific policies that you would recommend to leaders in Washington or state capitals as you're doing now?
If there was one bold, effective policy that I would want to bring home to policymakers, both on a state level and on a federal level, it is the idea of removing health insurance from primary care. Health insurance does not belong with primary care. It never belonged with primary care. In any insurance industry, insurance is for catastrophic and unexpected results. And primary care is neither catastrophic nor unexpected. What happens in a primary care setting, these are not insurable events. It doesn't make sense for health insurance to be involved with primary care. So the way to do this is to create a common fund run by the state, a primary care fund that pays for primary care. Essentially, it becomes direct primary care for all because it's providing prospective monthly payment for primary care directly to practices. So instead of having clinicians who are burnt out, feeling the need to leave their practices and reduce their panel sizes dramatically to go into direct primary care or concierge. Now you give folks the option of having direct primary care while staying in their practice and not reducing their panel size. So I think this is the fundamental policy shift that would be a complete game changer. Another way to look at this, Todd, is single payer for primary care.
Well, last question for you here. It touches a little bit because you've already given me one really bold idea. So I don't know if I can make you think even more bold, but this is my favorite question, and I like to ask it at the end to let people really end on their dream scenario. Uh, Thinking, in the same vein, or maybe even bigger than what you just were proposing, if you could wave a magic wand and you could change one thing about the healthcare system overnight, what would it be?
Well, I did misplace my magic wand, but if I find it and I could wave it, Todd, um, as you are requesting, let's go bigger picture. Ultimately, the ills of our healthcare system are based on the fact that the fundamental forces in our healthcare system that drive how our healthcare is administered in this country, it's all based on profit. Health and equity have a backseat. Profit is the overarching force in how healthcare is administered in this country. So, at the very least, I would love health and equity to be put on the same playing field as profit. This is a capitalist society. That's fine. We can have profit, but can we have health and equity too?
I think that is a very valid goal. I think it's hard to argue with health and equity being the ultimate goals. Well, thank you very much, Wayne. I really appreciate you joining us, and this was a fantastic conversation. And we're so grateful for all the work that you're doing and for the passion and the bold ideas that you continue to bring to the community.
Well, thank you so much to the Primary Care Collaborative for your national leadership in primary care and for recognizing myself and our whole team in Massachusetts for the work that we've been doing with PC for You. Much appreciated.